Okay, so Bismillah Rahman Rahim. I welcome all of you for this diabetes dialogue session by FarmEvo, and we're very much thankful to all our panelists for joining in and our speakers as well. So before starting the session, let us first start with the recitation of Holy Quran. Bismillah Rahman Rahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad, wa lam yakul lahu kufuwan ahad. Sadaqallahu al-azim. So formally starting our session, and diabetes dialogue is basically it's an academic initiative by FarmEvo, in which we will be discussing about some specific decision making that the physicians have to take while managing diabetes. And our today's first topic is about the choice of the combination therapy when you are moving from metformin to SGLT2 or Dpp4. So let me first introduce with our speakers for today's sessions. Our first speaker is Dr. Ali Asghar, and Dr. Ali Asghar is assistant professor and consultant endocrinologist at the National Hospital, and as well as he is the vice president of Pakistan Endocrine Society. Our second prestigious speaker is Dr. Umar Yousaf Raja. He's from Islamabad Shifa International Hospital. He's a consultant endocrinologist, and he's also a very well-known name in Islamabad. So it's a geographical, basically, discussion from one speaker is from Karachi, one is from Islamabad. Now coming to the panelists, so our out of four panelists, and number one is Professor Najmul Islam. He's section head of endocrinology at Khan University Hospital. So thank you very much for joining in. The second panelist is Dr. Osama Ishtiaq. He's a consultant endocrinologist in Shifa International Hospital, Islamabad. And Dr. Qamar Masood Sahab, he's associate professor and consultant in Khan University Hospital. And last but not the least, we have Dr. Mazhar Mufti with us, who's basically a medical consultant and consultant physician at Shifa International Hospital, Islamabad. So again, we have two panelists from Karachi and two from Islamabad. So she's going to unmute all again, and I would request our speaker. Okay, so I just muted all again, so I'll be managing the mute as well during the session. So without any further delays, let us first go for as per our agenda. The first talk that we are going to have is by Dr. Ali Asghar. So I would request Dr. Ali Asghar to please share his screen. I'm going to stop sharing from here. Dr. Ali Asghar, please share your screen.
Temu, do you get the first slide of mine, management of type 2 diabetes?
Yes, sir, it's clear. You can just start.
Thank you very much. Bismillahir Rahmanir Rahim. Assalamu alaikum, everybody. It's a fantastic, I hope it's going to be a fantastic session on management of type 2 diabetes. Thank you very much, FarmEvo, for this diabetes dialogue. I welcome Dr. Umar Yousaf Raja. I've heard you're a lovely speaker. This is going to be the first time with you, Umar. So it's going to be pretty interesting. With the permission of the honorable panelists, my teachers, Professor Dr. Najmul Islam, Dr. Qamar Masood, and Dr. Osama Ishtiaq and Dr. Mazhar Mufti, I would like to start the session and my part in this. So when me and Temur, we were discussing this, we thought whether it should be one with Dpp4 inhibitor and the other speaker going for SGLT2 inhibitor. But truly speaking, both these medications are so fantastic that I think we decided that we're going to go forward with both medications, probably with both the speakers. So combination therapy with metformin, SGLT2 inhibitors or Dpp4 inhibitors. Now, what are we discussing today? So these are some of the wonderful hospitals in Karachi that I'm blessed to work in. So we all know that diabetes prevalence in Pakistan is increasing at a staggering rate. I mean, 1 in 5 adult Pakistanis are diabetic. This is a huge number, and this is why on a Sunday 4 p.m. all of us from all over Pakistan are sitting here talking about diabetes. These are the complications of diabetes. I know from head to toe, diabetes has got its complications. Now, when we sit here, when we talk, what should be the combination therapy with metformin, whether it should be DPP4 inhibitor or SGLT2 inhibitors, we are actually talking about preventing the complications of diabetes. Diabetes की management ये नहीं है कि हम सिर्फ HbA1c control कर लें, fasting blood sugar control कर लें. The real crux of diabetes management is to prevent our patients from going into these microvascular and macrovascular complications. And we all know that reducing the HbA1c down by just 1% will give us the following benefits. The death related to diabetes goes down by 21%, microvascular complications down by 37%, myocardial infarction down by 14%. So this is the real goal of diabetes management. It's not only the numbers that we are going to manage, it's the whole spectrum of these microvascular and macrovascular complications that we need to prevent as a good diabetes specialist, as a good physician or an endocrinologist. So when we talk about therapy for type 2 diabetes, I mean, this is the step ladder pattern that we have been taught right from our training years. Now, we all know that diet and exercise is the core. Nothing will stand if we do not do diet and exercise. I mean, patients have to do diet and exercise. Then obviously it is monotherapy that usually we begin with. And when we talk about monotherapy, well, most of the guidelines still in 2020 would suggest that metformin is the monotherapy. And after metformin, we go towards combination therapy. And this is what the whole presentation we are talking about today is. We are talking about combination therapy. What after metformin? So we have started somebody on metformin. The patient is uncontrolled diabetes. What should we give next? DPP4 inhibitors or SGLT2 inhibitors? Now remember, it's not only the control of diabetes that we are looking at. We are looking at preventing our patient from going and tipping into the complications of diabetes. That is the real business, right? So what after metformin? I mean, what is the best fix to metformin? Now, somebody would say DPP4 inhibitors. Somebody would say, well, SGLT2 inhibitors. Well, it's still, we are working on it. We are thinking what should be the second line agent, ideal second line agent. Now, the reason that we are talking about both these agents in both these talks is that things are different. I mean, not every patient is the same, and the diabetes management is not only a stereotype pattern of medications. Diabetes management is looking what your patient needs are. आपके patient को किस चीज की जरूरत है? So what do we want in a second line agent? Now, first of all, we want HbA1c reduction. जो भी दवा हो, HbA1c reduce करे. No major hypoglycemia. We don't want hypoglycemia in the second line agent, right? It should reduce the CV risk. Renal benefits होने चाहिए second line medication के. It should reduce weight because most of my diabetes patients and your diabetes patients would be overweight and obese. Well, it should also control blood pressure. I mean, that's the imagination and the things that we need to have. And it should preserve the beta cells. It should be once daily dosing for better compliance, and it should be the most economical option. Now, these are the things that I'm looking at for a second line agent after metformin in diabetes. Now, I'm going to go and discuss all of these factors one by one and take both DPP4 inhibitors and SGLT2 inhibitors and show you what's going on both these platforms. So first of all, efficacy. Now remember, forget everything. Forget that it's a Sunday. Just consider yourself in the clinic. You're sitting in the clinic. Your patient is on metformin. You're choosing a second line agent. You've got two options. You've got DPP4 inhibitors. You've got SGLT2 inhibitors. What will you choose? What are the factors that you look at? And then you'll decide what medication you want for your particular patient. Efficacy, reduction in HbA1c. Dawa kaam bhi karegi ki nahi? This is the biggest thing. So looking at the DPP4 inhibitors, well, reduction in HbA1c is 0.8 to 1.1%. SGLT2 inhibitors, 0.6 to 1.0%. Studies have shown less and more, of course, but this is what I could got from the average studies. DPP4 inhibitors probably just a little bit more than SGLT2 inhibitors in reduction in HbA1c, but from the technical standpoint, I think both of them will be doing the same thing when we give it to patients. So this is SGLT2 inhibitors. In monotherapy, it reduces HbA1c from 0.6 to 0.8%, almost the same reduction in HbA1c when you add it on to metformin. This is DPP4 inhibitors, again, somewhere 0.6 to 0.8% at monotherapy. And again, when you give with metformin as a second line agent, this is the A1C reduction. So you see, in terms of efficacy in reduction of HbA1c, I mean, most studies would show SGLT2 inhibitors and DPP4 inhibitors doing almost the same job in terms of HbA1c. Coming on to weight, number 2, weight. What is the impact on weight? So I know that whether I use DPP4 inhibitors, whether I use SGLT2 inhibitors, both are reducing 0.6, 0.7% to somewhere close to 1%. Good. What next? Impact on weight. So I always say it's not only about numbers. We also want weight reduction in our diabetes patients. So what is the impact on weight? Now, most of the diabetic patients, studies suggest that 80–90% of the diabetic patients will be overweight and obese, and we want to reduce weight. So why are we worried about weight? So this is it. 1 kilogram increase in weight, 3% increase in cerebrovascular disease. तो एक तरफ मैं डायबिटीज को कंट्रोल करके HbA1c 6% पे ले आऊं और दूसरी तरफ मैंने वेट 5 किलो मरीज का बढ़ा दिया, तो I have not given any benefit to the patient. So whatever treatment I am choosing for my patient, we have to reduce weight. DPP4 inhibitors, they are weight neutral. They will not increase weight, they will not decrease weight, weight neutral. Well, studies say that they can reduce up to 1 kg weight, but technically they are weight neutral. SGLT2 inhibitors, 1.5 to 2 kilogram weight reduction. 2 kilogram weight reduction means 6% decrease in cerebral cardiovascular events. And this is a good job in terms of SGLT2 inhibitors. So again, you see DPP4 inhibitors, no effect on the weight. SGLT2 inhibitors, almost 1.74 kg weight reduction. Now, this means that if I want to reduce weight in my patient, there is a lot of voice coming in the background. Taimur, can you mute everyone else, please? So if you want to reduce weight, of course, now SGLT2 inhibitor is a much better option. Now, in my practice, and I know in most of the endocrinology, in most of the Taimur, can you hear me now? Are you hearing me, Taimur?
Yes, doctor.
Yes.
Okay,
yes.
great. So moving on to hypoglycemia. Now, we don't want hypoglycemia. Why we don't want hypoglycemia? It increases weight. Now, because hypoglycemia, you're going to eat again and again, you're going to increase your weight, which will increase the CV events. Hypoglycemia will directly increase the CV events. Sympathetic response activate ho jayega, heart attack, strokes. Increases cost in hospital admissions, hypoglycemia. And the most important thing is the patient will not trust us anymore if he goes into hypoglycemia. So as a physician and diabetes expert, we do not want hypoglycemia. So both DPP4 inhibitors and SGLT2 inhibitors, I mean, very low chance of hypoglycemia with both of them. But again, if you're using them with sulfonylureas and insulin, of course, you're going to get hypoglycemia, but that's because of the sulfonylureas and the insulin rather than the DPP4 inhibitors and the SGLT2 inhibitors. So in terms of hypoglycemia, I would consider both of them equal in not giving hypoglycemia to the patients. Cardiovascular safety is very important, right? Now, why the cardiovascular safety is important? Because whatever we are doing in terms of managing diabetes, असल में तो हम cardiovascular morbidity और mortality को कम करना चाहते हैं. We know that 85% of type 2 diabetes patients will die from heart attack or stroke. तो अगर heart attack और stroke से diabetes के मरीज की अमवात होनी है, तो हमें ऐसी दवाइयां चूज करनी है कि हम cardiovascular mortality और morbidity को कम करें. So DPP4 inhibitors, they are safe. SGLT2 inhibitors, empagliflozin reduces cardiovascular mortality. Now, these are certain drugs that I would discuss. Vildagliptin, huge meta-analysis, 40 trials, 17,000 patients declared vildagliptin safe for cardiovascular events. TCOS trial, landmark trial, 2015, declared sitagliptin, no added CV events compared to placebo. This is dapagliflozin, the MACE, almost similar to placebo, not statistically significant, not more than placebo, of course, all-cause mortality of dapagliflozin, same as placebo. So again, dapagliflozin also cardiovascular safe. Empagliflozin, EMPA-REG trial, 2015, 7,000 patients, 38% relative risk reduction in cardiovascular mortality. So, I mean, you see most of these medications, DPP4 inhibitors, they are safe in terms of cardiovascular disease, and empagliflozin will reduce cardiovascular mortality in patients. Now, there are many nitty-gritties that we can talk about. but I know that I want to make this presentation very simple for all of us to understand what should be our second line agent. So cardiovascular safety, yes, the SGLT2 inhibitors fare better. Empagliflozin, of course, reducing cardiovascular mortality. Use in atherosclerotic cardiovascular disease. Now, you all have heard that SGLT2 inhibitors are now becoming cardiovascular cardiologist medication, a nephrologist medication. Somebody having a heart attack, having PCI, I mean, DPP4 inhibitors, they are very safe. But SGLT2 inhibitors are recommended in somebody who is having heart disease or is at high risk or very high risk of getting heart disease. Use in heart failure. Now we'll touch upon the heart disease and the guidelines that I will show. Use in heart failure. So somebody has got heart failure. What would you use? Again, the DPP4 inhibitors, they are safe in heart failure, but SGLT2 inhibitors, they are recommended in heart failure. And I'll show you a few trials. This is the Dpp4 trial, which came late last year, 2019, 4,700 patients. And we saw statistically significant lowering in cardiovascular death, heart failure, hospitalization, and urgent heart failure visit with patients on dapagliflozin. And this is why our cardiologist colleagues are using dapagliflozin in heart failure without diabetes, because these Dpp4 patients were without diabetes. This is the Emperor trial, just released 9 days ago. Emperor trial. We don't have the full results, but we know that Emperor trial, the Emperor reduced trial, heart failure, ejection fraction, low ejection fraction with heart failure, right? 2020 just released 10 days ago. Pure results abhi nahi aaye, but we have been told that empagliflozin also is doing the same thing as dapagliflozin, improving the heart failure, right? And this is the biggest thing. So you see, cardiologists are enjoying this medication. They are giving it in their heart failure patients. They are giving it in their patients with atherosclerotic cardiovascular disease to lower the mortality in heart patients. What about kidneys? Now, my nephrologist colleagues, they call me, they tell, well, look, we are looking beyond diabetes to these medications, the DAPA and empagliflozin. Again, impact on the kidneys. DPP4 inhibitors are safe, we can use it, but SGLT2 inhibitors are beneficial for the kidneys. Now look, SGLT2 inhibitors are beneficial for the heart as well, they're beneficial for the kidneys as well. So what goes? This is the EMPA-REC trial, empagliflozin trial. Significant relative risk reduction of 39% in incident or worsening nephropathy, and relative risk reduction of 38% in progression to macroalbuminuria with empagliflozin. And now these medications are also being studied without diabetes. The DAPA-CKD trial just released a few months ago showed that even without diabetes, dapagliflozin is giving significant benefit in CKD patients. And I mean, there are very limited choices in terms of medications for CKD, and cardiologists are using these SGLT2 inhibitors without diabetes. Nephrologists are using these medications without diabetes. So, I mean, these are the renal benefits of SGLT2 inhibitors. So I just wanted to give this slide to you all. I will not go into the details. You can go on and study this. Now, what about the usage in chronic kidney disease? Now, if you see chronic kidney disease, the DPP4 inhibitors should be used at the GFR of more than, SGLT2 inhibitors should be used at the GFR of more than and equal to 45. And DPP4 inhibitors can be used even in end-stage renal disease, although dose adjustment is required. 50 से कम GFR पे sitagliptin half dose हो जाता है 50 milligram और 30 से कम पे 25 milligram. Vildagliptin 50 से कम पे 50 milligram once daily हो जाता है, and that can continue in end-stage renal disease. But SGLT2 inhibitors start with a GFR of more than 45. Studies are ongoing. कहते हैं 30 और 45 के बीच में you can continue with caution. You have to be very careful. 30 से कम पे बिल्कुल contraindicated है, नहीं देना. Duration of diabetes. Somebody comes to you with 2 years of diabetes. Somebody comes to you with 20 years of diabetes. क्या देंगे second line agent metformin के बाद? DPP4 inhibitors, SGLT2 inhibitors. Pancreatic function कैसा है? Beta cell reserve कैसे है? So DPP4 inhibitors, well, it is dependent on the pancreatic beta cell reserve because it's going to help the beta cells release insulin. But SGLT2 inhibitor is independent of pancreatic beta cell reserve. This means that DPP4 inhibitors will work best in early diabetes where you have beta cell reserve. SGLT2 inhibitor but we need to know that the DPP4 inhibitors, most trials say reduce LDL-C by a few milligrams, and SGLT2 inhibitors increase LDL-C by a few milligram points. But we all know that SGLT2 inhibitors reduce cardiovascular mortality, and this is very important. So how much role does this play in overall management? We can debate on this, but we should know it. This is the same thing that is shown here. So what the guidelines say? I mean, ये तो हम बात कर रहे हैं HbA1c, weight, hypoglycemia, cardiovascular safety, heart failure, CKD. What the guidelines suggest? So DPP4 inhibitors पहले तो metformin के बाद बिल्कुल second line पे हम दे देते थे. But now a little bit it is going from second line to third line medication. I can tell you. SGLT2 inhibitors second line treatment, but study मैं आपको बताऊंगा guideline जो first line भी इसको recommend कर रहे हैं in heart patients. So let's see, this is Diabetes Care, October 2018. Metformin is the first line treatment in type 2 diabetes. अब अगर atherosclerotic cardiovascular disease है, तो second line SGLT2 inhibitor या GLP-1 analog है. अच्छा देखिए, हमने GLP-1 analog पे स्टॉक में बात नहीं कर रहे हैं. उसकी रीजन ये है कि GLP-1 analog हमारा टॉपिक नहीं है. हमारा टॉपिक DPP4 inhibitors, SGLT2 inhibitor है after metformin. GLP-1 analogs are very बहुत कम मरीज ले पाते हैं. So again, atherosclerotic cardiovascular disease में second line agent is GLP-1 analog, SGLT2. Third line DPP4. Heart failure और CKD है तो second line SGLT2, third line GLP-1 और फिर DPP4 inhibitors. If you want to reduce the weight of the patient, then first line is metformin, second line is GLP-1 analog and SGLT2 inhibitor. और फिर DPP4 inhibitors की बारी आएगी. अगर hypoglycemia से बचाना है तो first line तो metformin है, second line DPP4 inhibitor, GLP-1, SGLT2 inhibitor, thiazolidine-dione. So these were the guidelines 2018. ये 2019 European Society की guideline है. इन्होंने पूरा dynamics change कर दी है और पहली बार इन्होंने पहली बार जो है metformin को first line से हटाया. I'll show you. So इन्होंने तीन categories बनाई. Very high risk, moderate risk. अच्छा, high risk में देख लें diabetes 10 years with any other risk factor. यानी hypertension है, dyslipidemia है, diabetes more than 10 years है, ये सारे के सारे high risk में चले गए. They said that there are two diabetes की दो उन्होंने category बना दी. Drug naive diabetes जिसमें पहले से कोई drug नहीं मिला. अगर उसमें atherosclerotic cardiovascular disease है या high या very high risk है तो आप SGLT inhibitor या GLP-1 monotherapy से start करें. Not metformin. अगर atherosclerotic cardiovascular disease है या high risk या very high risk heart CV risk है तो आप SGLT2 inhibitor या GLP-1 analog से start करें. बाद में metformin दें. और अगर किसी को metformin already चल रही है लेकिन उसको भी heart disease है या CV high risk या very high risk है, regardless of the HbA1c, you can add SGLT2 inhibitor or GLP-1 analog. Now this is a shift from the traditional metformin as first line therapy. ये पहली बार किसी guideline ने कहा कि आप SGLT2 inhibitor को भी first line therapy use कर सकते हैं in atherosclerotic cardiovascular disease. I mean, I'll just take a couple more minutes. Age. What age is safe? DPP4 inhibitors you can give in elderly as well, but SGLT2 inhibitors elderly में थोड़ा सा हमें cautious रहना है. बिल्कुल दे सकते हैं, but little cautious. एक मरीज है जो बिस्तर पे है जिसको बार-बार अपने बच्चों को पानी के लिए बोलना पड़ता है कि मुझे पानी दे दो, उसको आप SGLT2 inhibitor देंगे, a glass or two extra urine, probably वो शर्माएगा अपने बच्चों से बार-बार पानी मांगने के लिए. तो बहुत देखने की जरूरत है कि हमें elderly में caution के साथ देना है. कोई बार-बार वॉशरूम नहीं जा सकता, किसी को प्रोस्टेट डिजीज है, ऑलरेडी बार-बार वॉशरूम जा रहा है यूरिनेशन के लिए, उनमें बड़ा कॉशियस रहना है. एल्डरली में दे सकते हैं SGLT2 inhibitor, but you have to be cautious. स्टडीज ने भी कहीं ना कहीं 70-75 इयर्स पे कैप लगाया. पाकिस्तान में भी स्टडीज हो रही है, वहां भी हमने भी कैप लगाया एज के ऊपर. तो कॉशियस रहना है. SGLT2 inhibitors को एल्डरली में दे सकते हैं, but be cautious. Weather. DPP4 inhibitor you can give in any weather. SGLT2 inhibitor remain cautious in extreme hot weather. एक मेसन है जो कंस्ट्रक्शन कर रहा है, बिल्डिंग पे काम कर रहा है, उसको आपने SGLT2 inhibitor दिया, उसे 300 ml एक्स्ट्रा यूरिन आएगा, पानी कहां से पिएगा? शदीद गर्मी में डिहाइड्रेशन, हाइपोवोलेमिया कैन बी अ प्रॉब्लम. सो वेदर इज वेरी इंपॉर्टेंट. UTI and mycotic infections, DPP4 inhibitors safe है, SGLT2 inhibitors cannot be given. इस पे मैं ज़्यादा डिटेल में नहीं बता रहा. Recurrent UTI, current UTI में आप नहीं देंगे. Mycotic infection में SGLT2 inhibitors उस वक्त नहीं देंगे. Peripheral vascular disease, DPP4 inhibitors are safe, SGLT2 inhibitors again caution. क्योंकि वॉल्यूम कम कर देंगे तो पहले ही पेरिफेरल वैस्कुलर डिजीज है, फ्लो इंपैक्ट नहीं हो जाए, फ्लो हर्ट नहीं हो. सो अगेन आई एम जस्ट गिविंग पॉइंटर्स फॉर यू टू डिसाइड कि आपको कौन सी सेकंड लाइन मेडिकेशन लेनी है. ईज ऑफ एडमिनिस्ट्रेशन, DPP4 इनहिबिटर हो या SGLT2 इनहिबिटर हो, दोनों ओडी डोजिंग आप दे सकते हैं. Both are easy to administer, easy to take, both can be given once a day. Cost, दोनों की कॉस्ट सेम है, तकरीबन 1200 से लेके 1500-1600 रुपए महीने. SGLT2 inhibitors, thankfully to our local pancreas, you can. बहुत सारी चीजें मैंने आपको DPP4 inhibitors की बताई. Choice is in your hands. We cannot say that constant medication should be your second line agent. You as a physician need to individualize and see which medication comes next in your patient. अगर किसी का weight 50-52 किलो है तो आप उसको weight reduction के लिए SGLT2 inhibitor नहीं देंगे, उसको आप DPP4 inhibitor यूज कर सकते हैं. किसी को heart disease है, SGLT2 inhibitor यूज करने की जरूरत है. I mean, this is your choice. This is what is the message of the day, that well, first line is metformin. Second line, पहले तो सिर्फ DPP4 inhibitor होती थी. Now SGLT2 inhibitor is taking a lot of space from this DPP4 inhibitor. But the ultimate choice of a second line agent is in your hands. This is my Facebook and YouTube page, AA in Park. With this, I thank you very much. And I expect, Umar, you're a brilliant speaker coming up next. It's going to be a pleasure to listen to you. Thank you very much, everyone, for attending on a Sunday evening. Thank you.
Thank you very much, sir. I would request you to stop sharing of the screen. And okay. So our next speaker, first of all, thank you very much, Dr. Asghar, for a wonderful presentation. I would say that a very well defined segments for each and every alternate therapy of SGLT2 and DPP4. So wonderful presentation. It was lovely to watch. I would request Dr. Umar Yousaf Raja to please share a screen. You can share your screen now. I have enabled the sharing option here.
Okay. Umar, can you listen to my voice all right?
Yes, sir. It's okay. It's fine.
I think that's all basically. If I go for the last
Sir, I can see your screen.
Ali is a good friend. Ali is a good friend. लेकिन जो आखिरी साइड अली थी, ultimately it is a debate. It's a debate about metformin combination with either DPP4 or GLP-1 agonist. लेकिन एंड की स्लाइड में अली ने मुझे ज़्यादा कंफ्यूज कर दिया है कि जी ना एक तरफ he was protecting SGLT2 inhibitor and he was sort of basically ultimately was okay still question mark. So Ali, you know, I told you before that I'm going to taunt you. So in the word of, I'm a bit more confused. So in the word of Enrico Fermi, before I came here and I was confused about this subject, but having listened to your lecture, Ali, I am still confused, but on a higher level. So with keeping that inside, let me just go through my disclosures. And let's not forget, I mean, I have been a passionate supporter of SGLT2 inhibitors right when they came into the market. I was in UK at that time, over the last now 7 years. But when it came to, when you're thinking about, okay, as a generalized sort of basically statement, which should we be used after metformin, SGLT2 or DPP4 inhibitors, I think we need to remind that SGLT2 inhibitors are still newer kids on the block. And with the newer kids on the block, you have to be cautious because let's remember there was this rosiglitazone, a wonderful drug, but what happened with that MI fiasco and everything else? And that's why most of the guidelines is still saying metformin as a first line because metformin have got these 60 years where we are aware of what its side effects are, what sort of is in and out of metformin. So the longer a drug is there in the market, the more confident we are about this particular drug. Now, this is very much particular to your slide about whenever we are going to start medication, each one of us, what are the most important needs when we are treating someone with type 2 diabetes? Efficacy, as you are aware, is the paramount, because we knew that good glycemic control reduces risk of long-term complications. And for a particular drug combination, it should be at least non-inferior to another drug combination, if not superior. Safety, I think, is a paramount, because the most important thing here is that the drug should be safe. It should have less risk of hypoglycemia. It should be cardiovascular safe as well as the risk of other side effect or real side effect like fractures, gangrene, decay should be less to reach optimal efficacy. And ideally, as you mentioned earlier, it should be given once daily to promote medication adherence. It should be easy to use. It should be simple to use. And third and most important, in this evidence-based medicine era, it should have an evidence-based research. There should be definitely clinical trial to look at a particular combination to demonstrate the efficacy and safety of a particular combination in real life. So what do we want in a diabetes drug combination? That's the other thing. I think for me, and you have also alluded to some of those sort of basic points. When you look for a particular diabetes drug or even a combination of that, number one, it should be effective, yes. Number two, it should be well tolerated and safe, yes. Number three, it should be durable over a number of years. Number four, as you mentioned earlier, it should be cardiovascular disease safe. It should be weight neutral. It should be easy to give an oral once daily therapy. And also it should address underlying disease pathophysiology. And it should be cheap, especially in a country like Pakistan. So I will come through those one by one and see whether the combination of metformin and Dpp4 inhibitors fulfill those criteria or not. So let's look at efficacy again. Now, just to remind that the incretin effect, it's been well known even in 1960s that when the blood sugars or when the glucose is given orally, the insulin effect was much higher than when it was given intravenously. And it was thought to be due to this glucagon-like peptide or incretin hormones. The most important one was glucagon-like peptide, which in response to food intake promote GLP-1 or stimulate beta cells to produce insulin and suppress alpha cells. And we have shown that this effect would diminish in people with type 2 diabetes. So here on the right-hand side, you will see the incretin effect, it diminishes in people with type 2 diabetes. So the Dpp4 inhibitor, it's actually inactivate Dpp4 enzyme. So there is increased GLP-1 and GIP in the circulation, and that leads to glucose-dependent insulin secretion from the beta cell, which then promote peripheral insulin uptake, as well as reduce glucagon from alpha cells, which will then inhibit glucagon production and hence reduce hepatic glycogenolysis and gluconeogenesis. Metformin, on the other hand, actually works not only on intestine, where it promotes anaerobic it's also sort of basically act on the skeletal muscle to reduce fatty acid oxidation. Can you listen to me, Samad?
Yes, sir, we can listen to you.
Yeah, we just sort of be I think the light have just gone here, so we just hold for a moment. I think Ali ki jo thodi si sazish thi, isn't it, Ali? Okay, so coming back to that, look at the combination of Dpp4 and metformin. So Dpp4 on the one hand improve beta cell function and increase insulin synthesis and release, and on the other hand, it's actually reduce hepatic glucose output through suppression of glucagon from alpha cells. Metformin has insulin sensitizing properties, as you all know, and it's also decreased hepatic glucose output by reducing gluconeogenesis. So combining them actually address the pathophysiological effect. So there is clear-cut rationale for the fixed dose combination of Dpp4 inhibitor plus metformin as initial therapy. Number one is the mechanistic rationale. So here you can see that Dpp4 inhibitor offers a clinically important outcome when added to metformin with a twice daily dose regime or simply daily dose regime. And I've shown you the pathophysiological mechanism behind. And there are synergistic effects. So higher intact GLP-1 level with the combination. Then there is clinical rationale because you are getting equivalent or superior HbA1c loading without the GI tolerability issue associated with higher dose of metformin. And there is no risk of hypoglycemia. And then there's a compromise rationale because you are getting actually both combination drug in a single pill, which actually improve patient compliance. So look at the data, sitagliptin metformin combination. So sitagliptin 50 plus metformin 1000 twice a day. Actually, you can look at that it can lead to a 2% reduction in HbA1c from a baseline of 8.5%. And here you see that around 60% of people reach the HbA1c target of less than 7% after 104 weeks, so 2 years, with sitagliptin 50 milligram twice a day and metformin 1000 milligram twice a day. If you look at the lower dose of combinations of sita 50 and metformin 500 milligram twice a day, it's equivalent to the highest dose of metformin that we tend to give in people. So it's equivalent for 5% in this respect. And also the higher the HbA1c is, the more better effect on the the higher on the HbA1c with the combination. So here you see with the vildagliptin metformin, if the baseline HbA1c more than 10%, we're actually looking at 3.2% reduction in HbA1c, which is quite important. And as Ali have mentioned earlier, that it's non-inferior. So actually, if you look that when you combine that with SGLT2 inhibitors, so here if you look at the difference between sitagliptin and canagliflozin 300, and I would argue that canagliflozin 300 maybe is the most potent of all the SGLT2 inhibitors in the market yet. The treatment difference is 0.7%, which is statistically non-significant. In fact, if you look at the SGLT2 inhibitor, which is available in Pakistan, so dapagliflozin, and compare sita with that, there's a composite R study which shows that with sitagliptin, there 15% more patients achieve target HbA1c than with dapagliflozin. So here it's showing a bit more superiority than the dapagliflozin. So what do we want in a diabetes drug combination? Effective? Yes, it is, as I've shown you. It gets patient to goal. And as I've shown you earlier, it addresses underlying disease pathophysiology. What about safety? And I think that's the most important thing that we need to understand, because 2000 years ago, Hippocrates, father of medicine, have uttered these words: primum non nocere, first rule of medicine, first do no harm. And we knew that now, gone are the days when diabetes is being classified as type 1 or type 2. Basically now, a cities group have actually divided diabetes into 5 clusters. And look at the cluster number 5, mild age-related diabetes, where the highest population or proportion of your patient with type 2 diabetes lie. These are the patients where you are actually requiring a modest HbA1c effect, but you want to be safe. And when it came to safety, which drug is better? I'm sure even Ali will agree to that, that it's going to be the Dpp4 inhibitor. Because with the Dpp4 inhibitors, let's not forget that it does not suppress the GLP-1 agonist, it also increases the GIP. And GIP actually increases glucagon if there is hypoglycemia. So here you can see the dual effect of GLP-1 and GIP. So GLP-1 promotes insulin secretion and at high glucose levels suppress glucagon. GIP, the effect on insulin secretion is questionable, but at lower glucose level, it actually promotes glucagon, hence preventing hypoglycemia. So there's a mechanistic effect behind hypoglycemia, or why there's less hypoglycemia with Dpp4 inhibitor. So not surprisingly, if you use vildagliptin in combination with insulin, there's 40% fewer incidence of hypoglycemia, and there's no severe hypoglycemia. Equally, if you combine vildagliptin with, say, metformin and sulfonylurea, you will see that the risk of hypoglycemia is 1.9% as compared to 5.1%. And similarly, it is weight neutral. So on the left-hand side, you will see that the vildagliptin metformin combination is weight neutral. Again, here you can look, this is the composite endpoint of HbA1c and body motivate with sitagliptin at week 52. And what you are sort of basically requiring, or what you want, is that most of those, each box or each dot is one patient, and most of them should be right on the left side and beneath this line. And see, most of those dots are lying on the line, indicating that this is weight neutral. And let's not sort of forget that sitagliptin is or DP4 inhibitors are the only one that you can give right up to end-stage renal failure. No other medication can be given right up to the end-stage renal failure except for insulin, and we knew that insulin is injectable. So DP4 inhibitor is safe to use in renal impairment. There is some data, I'm not going to go into that, about that is reduced albuminuria as well, it's kidney protective as well. But important thing is, what if your patient are coming with diabetes and end-stage renal failure or EGFR of 15%? You are not going to give them a SGLT2 inhibitors, you are going to give them a DP4 inhibitors. And what about the safety? Now, early have actually mentioned to this pancreatitis effect, and actually I would argue that this pancreatitis is actually a complication of type 2 diabetes, not to the particular drugs, because you look at the GLP-1 data, you look at the Dpp4 data, and the pancreatitis is pretty much similar. So here you can see it's a verifying study. I will come to that study later on, but look at the arthralgia, pretty much similar numbers, whether you're using a recombination with built-up and metformin or with initial monotherapy. Pancreatitis, 10 cases in early combination, 9 cases in initial monotherapy. UTI, pretty much the same. So again, emphasizing that it's a safe drug. If you think about, well, it is only related to build-up-gliptin. This is a study about is a SAVOR trial on saxagliptin. Again, look at the any pancreatitis. In fact, less than the placebo. What about pancreatic cancer? Less numerically than the placebo, showing that this association of pancreatitis with DP4 inhibitors is at best a myth. It's diabetes, type 2 diabetes that causes pancreatitis, not the drugs. Cardiovascular safety, where is cardiovascular safe? I'm showing you, well, earlier I've shown you the TCOS study, and on the right-hand side is examiner trial in allogliptin, and you know that the worms are superimposed. So when you look at the safety, is it well tolerable and safe, our combination? I've shown you yes. Is it cardiovascular disease safe? I have shown you yes. Is it weight neutral? I have shown you yes. And let's not forget about SGLT2 pitfalls. What about the DKA? Look at the meta-analysis of 10 randomized controlled trial. 13,000 patients showed DKA even rate of 0.1% with SGLT2 inhibitors versus 0.06 in control. 0.1% mean 1 in every 1,000 person might get a DKA. And looking at our current prevalence, if you think about that, we have got around 2 crore population with type 2 diabetes, and you start even half of them, 1 crore, on a combination of metformin and SGLT2, you're looking at 100,000 DKAs. Where does that all those go? You're looking at maybe 10 to 15,000 mortality only by looking at that particular mortality. So I think we have to be cautious in choosing our combination. What about general tracking? Early have actually mentioned to that. So 4.8% with dapagliflozin as compared to 0.9%. 4.3% UTI as compared to 3.7%. And with genital tract infection, you have to understand that most of that will happen in females, and females are not going to mention it to you because of our cultural barriers. What they are going to say, they are going to go to their gynae doctors, they don't know which is causing them, and they will keep on getting this repeated sorts of antifungal creams, and it will impact their quality of life as well. Risk of toe amputation. So you have to be cautious in using people who have got diabetic ulcer. And what about this corneal gangrene? That's something that I'm going to want to have. The mortality is nearly 100%, and there are case reports of SGLT2 inhibitors causing corneal gangrene. So safety is paramount, and you will see with SGLT2 inhibitors, there are sort of these problems as well that you are not going to get with the Dpp4 inhibitors. What about ease of use? Now, we knew that the results from randomized controlled trial are not always observed in real-world clinical practice. So this is the gap here, and that gap is mostly explained by medication adherence in the real world, which is thought to be a key contributor to the efficacy of a particular combination. We knew that if you give a tablet once a day, the adherence is better. So If someone is taking the drug once a day, 98% adherence as compared to twice a day, which is 83% adherence as compared to 3 times a day, where it's dropped to right up to 65%. With a DP4 inhibitor and DP4 inhibitor, you will get a sustained or combination with metformin sustained release, which not only help in improving patient adherence, but also have a better tolerability because of the sustained release metformin, which have got less GI side effects. So basically, what you are getting is an improved pill burden, improved tolerability, leading to improved HbA1c. And we knew, as I mentioned earlier, the primary goal is to achieve glycemic control. And let's not forget, it's 1 tablet a day. It costs roundabout in Pakistan between 1 tablet 36 rupees to 39 or 40 rupees per day, as compared to when you give a combination of SGLT2 inhibitors and metformin twice a day, which each tablet costs about 27, 28 rupees. So it's half the cost that you're looking for in a country like Pakistan. So even it's cheap when you compare that with the SGLT2 inhibitors in Pakistani settings. So again, if you go back to our first slide here, is it available in oral once daily therapy? Yes, it is. It is cheap. Is it cheap? Yes, it is. And lastly, but not leastly, anything that we practice should have evidence-based research. There should be a clinical trial that shows that this particular combination therapy is effective in real-world practice. And we do have a verified study which actually study early combination therapy with vildagliptin and metformin versus sequential metformin monotherapy in newly diagnosed type 2 diabetes, which is a five-year multi-center randomized double-blind trial. The evidence does not go better than that. And you will not get that sort of evidence with metformin and SGLT2. You will only get it with metformin and DP4 inhibitor. So Verify is actually addressing patient in very early stages as compared to cardiovascular outcome trial. And basically, after running a running period of 3 weeks where patient was started on metformin, they were then randomized either to metformin and vildagliptin, which was early combination, or metformin plus placebo. And at 6 months, the treatment failure was defined at HbA1c more than 7%. So if you are on metformin, vildagliptin, and HbA1c goes above 7%, they stay on that. If they are on metformin and placebo, they move them to the metformin vildagliptin combination. And then at period 3 weeks or 1 year after the start of the trial, if you fail in both this trial, they start them on insulin. So the Verify study shows that the time to initial treatment failure was actually less with combination therapy, again metformin vildagliptin, than sequential therapy. So with metformin monotherapy, it's for 36 months. With metformin and vildagliptin combination, it was more than 61 months. And again, so more people benefit in longer term. And it's important to point out that around 15% never achieve the control. And it's so that tells us that right in the beginning, we should starting them on a combination therapy, but there will be 15% people who will not going to achieve this control. Okay, what about the, just hold for a moment, I think. So, my slides are slightly stuck. I'm just on the few slides now left.
Sir, you can just stop sharing and start sharing again, so it'll be fine.
Okay, hold on for a moment. I think I have to come back. So to basically give me 2 minutes, I will just switch off and then come back and then join it. In between, Ali is open to answer any questions. So just give me about a couple of minutes.
We are just waiting for a minute so that Dr. Umar Yousaf Raja can restart his presentation. So meanwhile, if from Dr. Ali Asghar's presentation, if someone has any question or any comments, so you're welcome to ask, because that part of the program, that is Dr. Ali's presentation, has already been done. So if there's any question, we can ask meanwhile, and then Dr. Umar Yousaf Raja can come back again.
Thank you, Temur. I think it's sorry that Umar has to pause. Meanwhile, we take questions. So the first question is, which one is better for long-term use, especially patients diagnosed at the age of 45 years? Which combination is better to safely use than in consistent use for 5 years? I mean, this is what we read. Now, as I said, I mean, Dpp4 inhibitors or SGLT2 inhibitors, you can use both of them. Dpp4 inhibitors, they are dependent on the beta cells, so obviously they're going to work more in early diabetes compared to SGLT2 inhibitors, which have a totally different mechanism working on the kidney, so they will be working with any duration of diabetes. As for your question, what should be consistent, I think Umar is back. Umar, are you back here?
Yeah, I'm back. I'm just going to share it. Sorry for the technical. Ali, ये आपकी साजिश हो रही है कहीं पे?
Umar, believe me, I mean, in Karachi we have got K Electric, और मेरे दोनों बेटे जो हैं, they are on standby. कि जैसे ही light जाए वो मेरे ऊपर flash करना start कर देते. They are both on standby. I'm surprised Islamabad has got the same problems like Karachi. Huh?
So.
So meanwhile, Umar, as you are looking, I'll just continue with the answer that I was given. So again, long-term use that has been asked. I mean, see, the SGLT2 inhibitors, we don't have studies spanning many years, but as far as the data we have at the moment, it's safe to use for the number of years that it has been used in the study so far. As far as DPP4 inhibitors are concerned, as far as you've got the beta cell reserve, Dpp4 inhibitors are going to work very well. So both can be used in long term, provided you have your choice to start that medication is spot on.
So if I can then start sort of basically, so I was mentioning about the Verify study, and I sort of basically have shown you that with the initial combination therapy, the treatment failure was more than 5 years with combination therapy as compared with the sequential therapy. And here you can see that people who achieve an HbA1c of 6.5% was much greater with the combination therapy than with the sequential therapy. And it doesn't matter if you look at subgroup analysis where your HbA1c lie, whether it's less than 7 or more than 7, or you are obese or lean, or you are elder or middle age, or you are male or female, or which race you are, or which area you are from, or where your EGFR is. It's pretty much when you are starting on the combination therapy, and the combination therapy, again, I will emphasize, was between the metformin and Dpp4 versus metformin alone, the combination therapy stand better. With the low risk of adverse events. So here you can see that the comparison with the initial monotherapy and early combination is pretty much the same. So basically again showing that Dpp4 inhibitor and metformin combination is as safe as metformin alone. And Ali have mentioned about the guidelines, and he went through quite nicely to different guidelines. But Ali ने कहता जो है ना वो बेस से पढ़ा है, अलिफ से नहीं पढ़ा. अलिफ जो है ना हर गाइडलाइन का ADA ESD की पहली गाइडलाइन में ये चीज आती है. All treatment decisions should be made in conjunction with the patient. And this is the ADA ESD 2012 position statement. Achieving glycemic target is essential, and glucose lowering therapies must be individualized. Must be individualized is the most important thing. And after metformin, combination therapy is visible, aiming to minimize side effect where possible. It's the minimization of side effect that I'm discussing is quite important. And then consider age, weight, sex, racial, ethnic, genetic differences, and comorbidities. So I agree with Ali on that aspect that if someone have got heart failure, maybe a combination metformin SGLT2 is better. But all the people that you want to start on combination therapy, I think you have to be cautious and decide which is the best one. Again, look at it 2020. Ali had mentioned that, but there is this decision cycle for patient-centered glycemic management in type 2 diabetes, which the first step is to assess key patient characteristics. Look at the current lifestyle, comorbidities, clinical characteristics, and then based on their individual decide on the combination. It's not about that on every person, you should be thinking about using metformin and SGLT2 inhibitors. You should individualize the treatment because 700 years ago, a very wise surgeon, Henry de Mondeville from France, have mentioned this. Anyone who believes that anything can be suited to everyone is a great fool because medicine is practiced not on mankind, but on every individual in particular. And with that, to summarize, I have shown you that metformin and Dpp4 combination is effective, is well tolerated and safe, has durable effect, as I've shown you in the verified study, is cardiovascular disease safe, is weight neutral, can be given oral as once daily therapy to improve adherence, address underlying disease pathophysiology, and is cheap. And with that, thank you very much. And again, sorry for those technical glitches.
Got it. Okay, so thank you very much, sir, for the presentation. And as far as both the presentations have been concerned, Dr. Ali Asghar and Dr. Umar Yousaf Raja both have actually placed their point of views regarding the use of SGLT2 and the Dpp4 inhibitors. So now we have a few panelists with us, very experienced endocrinologists with us. So I would like to request, first of all, Professor Najmul Islam, if you can hear us, so please put some light on both the presentations and what are your views about both the presentations.
Assalamu alaikum, everybody. I would first of all like to congratulate both the speakers for the excellent comprehensive talk in this 4 versus metformin with SGLT2. I mean, Raja was tilted towards using Dpp4 combination along with metformin, and Ali was towards combining SGLT2 with metformin. Both have their point of view, really effective drugs in terms of efficacy. Safety is also there in both group of drugs, but in terms of cardiovascular benefit, SGLT surpasses Dpp4 inhibitor. There are certain side effects with SGLT2, which we can euglycemic diabetic ketoacidosis. Pancreatitis has been mentioned as one of the Raja has shown is in his presentation that pancreatitis, though it is attached to Dpp4 and the GLP-1, is hardly the result of these drugs. But we have to be cautious. So, I mean, you have to individualize your these combinations in your patients. But the tilt in my practice is going towards combining metformin with SGLT2, obviously as a third line agent, then the Dpp4 comes in. But where there is a contraindication or the age is a limit, I go towards a combination of metformin and Dpp4 inhibitors. So I think there are pros and cons to both the medications, and we have to individualize our treatment when we decide about the combination. That's I have to say. Taimur, I've done. You can ask the others.
Okay, I would like to request Dr. Osama Ishtiaq to please put some light on today's presentations of Dr. Ali Asghar and Dr. Yousaf Raja. So Dr. Osama Ishtiaq, if you can hear us, would like you to share.
Yeah, first of all, very wonderful presentations by Ali as well as Umar. And both have done a really good job, especially Ali in defending the SGLT2 and Umar in defending the Dpp4. What I believe, some questions or some comments. like Dr. Umar has said that you have to decide individually about each patient. You cannot apply a particular drug on every patient. You need to decide individually whether this patient is suitable for a Dpp4 or whether this patient is suitable for SGLT2 inhibitor. Ali would agree with me that, and a lot of other who are practicing diabetes would agree with me that lot of our patients are uneducated, especially the ladies coming from very far off place. Very hard to educate them regarding the UTI as well as the genitourinary infections. So giving SGLT2 inhibitors to such patients would be a difficult choice. And if you prescribe a Dpp4 inhibitor in combination with metformin, you don't need to think about the side effects. But in case we are going for SGLT2 inhibitor with metformin, you need to think about side effects and need to educate the patient. And sometimes what you do if the patient is coming from a very far off place, giving an SGLT2 inhibitor along with the metformin, I would feel rather, for example, if the patient becomes or gets UTI or some side effects, he or she may not be able to contact me and ask for a change. And if I prescribe Dpp4 along with metformin, most of the patients, what I see, would keep on using them without any side effects. That's the problem with SGLT2. Like everybody would agree with me that they have to think about, and the results are very good in terms of cardiovascular safety as well as in terms of diabetic control as well. Another point we need to add over here is that a lot of our patients are very conscious about their weight as well. But I've seen a lot of patients are thin lean, they are type 2 diabetics, and sometimes they are very concerned about their weight loss, even with metformin as well. So a lot of times, most of the patients are actually telling us to stop this metformin. They read about the weight loss factor of metformin, especially on the internet. So giving SGLT2 inhibitor to such patients would further reduce their weight. So in this case, I would say that SGLT2, or rather than SGLT2, Dpp4 would have an edge, right? They are weight neutral. They tend not to cause weight reduction in these patients. But it's very difficult to decide because more and more drugs are coming in the market. It's very difficult to decide whether which drug to start, whether or Dpp4, whether an SGLT2 inhibitor. But it's your clinical judgment, individual choice, as well as the clinical parameters of the patient. Whether patient is very old enough, whether patient has a cardiovascular disease, whether patient has a heart failure, or whether patient has no complications associated with diabetes. So remember, not to give everybody a SGLT2 inhibitor or not to give everybody Dpp4. It's your clinical judgment. You have to decide on with experience that which patient needs which drug. I think that's all. Thank you so much. Over to Tamur.
Okay, thank you very much, sir. Thank you very much for the comments. So now we have a few questions. If Dr. Ali Asghar and Dr. Umar Yousaf Raja can see in the chat box. One of the questions was answered, that was related to the 45 years age person. The second question is from Dr. Muhammad Hafiz, and he's asking that when we use SGLT2 for a long-term use, it is affecting our kidneys when the glucose is secreted. So I think this question has been answered, or I would like Dr. Umar Yousaf Raja to please put some light on this question. It is related to the SGLT2 use and the kidney effect on kidneys.
Yeah, so I think it's more sort of basically because for a long time there was this myth that because the group diabetes presentation is like that you split excess glucose from the kidney, somehow it is going to be harmful. So for some people, this mechanism of action is like, what sort of mechanism of action is that? I think we need to understand that physiologically, nature-wise, we already have such sort of patients where we call renal glycosuria. And you look at those patients, they have got pretty much exactly the same thing and nothing happened to them. And with that sort of basically, we have got this natural thing already there with renal glycosuria. On top of that, I mean, it's been well proven now, and Ali have mentioned their declared TIMI trial. You can see Canvas creatine study is the, I would say, game changer when it came to the venous sort of basic protection. as well as now the Emperor. Most of those studies shows that if it's kidney protective, but again, it's not only the SGLT2 inhibitor, it's also Dpp4 inhibitor. Both of them have shown kidney protection, and seems like that both of them have got a different mechanism of action. So there is this thought that there maybe combining both of them will be maybe more beneficial for the kidneys.
Okay, great. So we have another question that is in combination with insulin or sulfonylureas in patients above 65 years of age, if you're using as an add-on therapy, which one is better, SGLT2 or Dpp4?
Which one do you want to answer? I mean, Ali or me? Now I can start sort of basically.
So you can give the answer.
It's to be honest, it depends upon the patient characteristic and what you are trying to aim, and which, regarding the duration of diabetes, how early they are in their duration of diabetes. If it's a longer duration of diabetes, then you would expect that maybe the alpha cells and beta cells might not be there, and in that case, SGLT2 inhibitor to me seems a more logical choice. If it's early stage, where you expect that there will be some beta cells and alpha cells left, then you would think about using the Dpp4 inhibitors as well. And then you need to look at the other comorbidities, whether they have got a history of heart failure or not, whether they have got chronic kidney impairment. A lot often I start metformin, especially with eGFR less than 30, I give them on insulin, and then any drug that I want to add, I add a small dose of Dpp4 inhibitors. So I think it depends on patient characteristic. Both can be given. Based on the other characteristic, you have to decide duration of diabetes, the weight factor, whether you want for them to lose weight, the history of heart failure or ischemic heart disease, and then decide which one to choose.
Okay.
I mean, there's no.
Okay, sir. So now I would request Dr. Ali Asghar to answer a question, and this is related to the use of SGLT2 in type 1 diabetes. So it's a very commonly asked question during this session. So Dr. Ali Asghar, please put some light on this question.
Thank you very much, Taimur. I think the audience question shows that they are very much interested in this Dpp4 versus SGLT2 inhibitors in combination with metformin. Now, type 1 diabetes is is a completely different topic. Now, if we see SGLT2 inhibitors, the dapagliflozin is approved to be given in type 1 diabetes in conjunction with insulin, of course, in Europe, but not in the US, where FDA is in control. And again, sotagliflozin can also be used in type 1 diabetes in Europe, but not in the US. But I think that both these SGLT2 inhibitors, sotagliflozin, which is not available in Pakistan, and dapagliflozin, which is available in Pakistan, although in the European Medicine Agency have approved them for type 1 diabetes in Europe, but we need to be very careful because I think if we look at the type 1 diabetes population in this part of the world, even people, they do not take insulin properly. So I think as far as type 1 diabetes is concerned, we should focus on treating more with the insulin, the basal bolus insulin, of course, rather than using SGLT2 inhibitors. हमारे जो लोग हैं ना, तैमूर, आप अगर उनको कहेंगे ना कि टाइप 1 डायबिटीज में आपको SGLT2 इनहिबिटर दे रहे हैं साथ में इंसुलिन के साथ, तो प्रोबेबली ये ना हो कि कहीं वो इंसुलिन ही छोड़ के बैठ जाए. वही जो डॉक्टर उसामा ने कहा कि एजुकेशन इज वेरी इंपॉर्टेंट इन दिस पार्ट ऑफ द वर्ल्ड. And I think that although these SGLT2 inhibitors are approved to treat type 1 diabetes in conjunction with insulin, लेकिन हमारे सेटअप में बहुत केयरफुली यूज करना चाहिए और सिर्फ एक्सपर्ट्स को यूज करना चाहिए विद प्रॉपर एजुकेशन. ये नहीं हो कि पेशेंट अपनी इंसुलिन जो है प्रॉपर यूज नहीं करे और डायबिटिक कीटोएसिडोसिस में टिप कर जाए. The other thing is we know that SGLT2 inhibitor from a 0.06% tips DKA up to 0.1%. और ये तो है ही टाइप 1 डायबिटिक जिनमें है ही इंसुलिन डेफिशिएंसी एब्सोल्यूट, तो इनमें डीके का चांस भी प्रोबेबली ज्यादा होगा. तो ऑल्दो के दो SGLT2 इनहिबिटर्स अप्रूव जरूर हैं टाइप 1 डायबिटीज को ठीक करने के लिए यूरोप में, हमारे सेटअप में आई थिंक दैट वी शुड बी अवॉइडिंग इट. और अगर हम यूज करें तो हमें बहुत ही एक्सपर्ट होना चाहिए और मरीज की पूरी एजुकेशन होनी चाहिए इफ वी आर यूजिंग इट.
Can I just add one more comment here? I mean, EMA ने भी allow किया हुआ है dapagliflozin को in type 1, but those who have got a BMI more than 27.
बिल्कुल, I mean I agree. If I add to basically, I think one of the reason कि FDA ने approve नहीं किया था वो यही reason थी DKA की fear की वजह से. और मैं इसको use करता हूँ लेकिन only I would say it कि in the tertiary care level या specialist setup में आप इसको use कर सकते हैं. I will not advise the family physicians to even think about using SGLT2 inhibitors in type 1 diabetes क्योंकि अगर DKA हो गया और वो मसले की बात यह है कि इसमें DKA में पता भी नहीं चलता क्योंकि यूजुअली जब होगा तो ब्लड ग्लूकोज कई दफ़ा नॉर्मल होगा, मिस हो जाएगा, and that's our biggest fear. So I think you have to be very careful. Just stick to your type 2 diabetes.
Okay, we have one last question, but before that, I would like to take comments from Professor Qamar Masood, who's our panelist. So, Dr. Qamar Masood, if you are available, please put some light on both the presentations. Also, there was a very high level of involvement from the participants, and they want to know some conclusive remarks. So, Dr. Qamar Masood, I request you to please share.
Can you hear me? Tamur, can you hear me?
Yes, sir. Yes, sir. I can hear you.
Good. I think I congratulate Farmibo for asking for this a very valid question and a very good debate, and I congratulate both Dr. Ali Asghar and Dr. Umar Yousaf Raja for very comprehensive and very enthusiastic presentations from both speakers. And I think this question was also raised, if I remember, when pioglitazone was flourishing in this part of the world, and when sitagliptin and vildagliptin came into the market, at that time there was a lot of hesitance initially from the pharmaceutical companies whether to go for there or whether they are going to have an impact on the market of the medication that was flourishing at that time, pioglitazone in this part of the world. But we saw with the time that sitagliptin became one of the very common choice and used very, very commonly in our population. The new kid in the block is not that new. Umar, you are saying that you have used it in UK. That was about 7 years ago. We were always looking for, and we have always been looking for a breakthrough in the management of diabetes. Physicians who are caring for people with diabetes, they always are looking for, because diabetes is a challenging disease, it's a difficult to control disease. So I think the new kid in the market, or the new kid in the block, is making its position. It's a very, I would say it's a very effective medication in the glycemic control. As Ali has mentioned, that it can be used even like 20 years down the road of diabetes. A Dpp4 inhibitors may be a very good choice in the initial course of diabetes, but we have seen that our patients, their diabetes do progress on the combination of metformin and sitagliptin, or the combination of metformin or vildagliptin. You can still hear me? Can you? Yeah. So that's why it's important that this SGLT2 inhibitors and the benefit in terms of heart failure, as well as in patients who are at high risk of atherosclerotic cardiovascular disease, like in DECLARE trial, which is TIMI 58. You can see that patients who had an acute MI in less than 2 years, there is a benefit of these medications, which is dapagliflozin was used in that trial. So not only patients with heart failure, admissions for heart failure, death from all cardiovascular diseases. So it has this medication, while with the Dpp4 inhibitors have shown safety, that they are safe to use in patients with cardiovascular disease, but have not shown any benefit in terms of reducing the cardiovascular death or cardiovascular mortality or admissions from heart failure or new stroke or MI. But this medication has shown a reduction mostly in the patients with heart failure, and also some reduction in patients who have atherosclerotic cardiovascular disease. Talking about the weight, our weights, our BMIs that we always quote for the Asians, we are as a population are becoming obese. We are not the same which we were about 20 or 30 years ago in terms of our weights and BMIs. So weight reduction, it's it's always beneficial in these patients, as Ali has shown. Patients with obstructive sleep apnea, pulmonary artery hypertension, decrease their physical deconditioning. All these things occurs with the weight gain. So quality of life in terms of weight reduction is also there. Improvement in the quality of life. Though there are some cautions with these new medications, the patients have to be counseled what to expect. Like if when we start these medications in the beginning, we have to explain to them that they may have increased frequency of urination, at least in the beginning. So they should be aware of it. They should be cautioned about urinary tract infections. If there is an infection, they have to stop. And during an acute illness too, if they get really sick, need to go to the hospital at this time, this medication has to be stopped at that time as well. But I consider it as a breakthrough medication after a long time in diabetes care. I thank you, and I congratulate again the both speakers. They have done an excellent job. Thank you very much from my side.
Thank you very much, Dr. Qamar Masood, for sharing your insights regarding the presentations. And at the end of the presentation, I would just like to share one thing with you. Both the talks that were done by our prestigious speakers, respected speaker, Dr. Yousaf and Dr. Asghar. So, however, as far as the conclusion is concerned, it's up to the participants, depending upon what they understood from these wonderful presentations from Dr. Asghar and Dr. Yousaf Raja, and the comments from our panelists. So the choice is yours, whether you go for SGLT2 or Dpp4, and the main purpose is basically a good management of diabetes for the patients. So I thank you, our panelists, and I thank the speakers, Dr. Umar and Dr. Asghar, for their time and wonderful presentations. So on behalf of Farmivo, I really thank all of you for joining in on this Sunday. And inshallah, we wish to have some more discussions in future related to this topic. Thank you very much.
Thank you, everyone.
Thank you very much, Temo. Thank you very much, everybody. Thank you, Dr. Umar, Professor Islam, Dr. Qamar, Dr. Sama, for joining us and making this very interesting and enthusiastic. Thank you very much.